Okay, so now we're gonna see a follicular cyst, which is a dentigerous cyst. An odontogenic cyst, always associated with the crown of an unerupted or developing tooth or dental anomaly, i.e., odontoma. So, dentigerous cyst or follicular cysts, most commonly found in relation to a developing third molar. Enlarged dentigerous cysts can cause marked displacement of teeth due to pressure of accumulated fluid that usually displaces the tooth in an apical direction. If a tooth with a dentigerous cyst begins to erupt, the bulging the cyst produces on the ridge is an eruption cyst. Clinical features of dentigerous cysts found in children and teenagers in mandibular third molars and maxillary canine area 70% of the time. So, mandibular third molars and maxillary canine area 70% of the time associated with impacted or unerupted teeth is the second most common odontogenic cyst. Okay. Radiographic features, well defined, usually unilocular radiolucencies. Histologic features lined by non-keratinized stratified squamous epithelium, and red apex are absent. Non-keratinized stratified squamous epithelium with absent red apex. And a meloblastoma is most likely to develop in the wall of a dentigerous cyst. Now, a traumatic bone cyst. A traumatic bone cyst may be completely devoid of solid or liquid material, but may contain blood, fluid, debris, or it can be completely empty. It is most commonly found in young people with no sex predilection in the mandible between the canine and the ramus. So it's going to be in posterior area. That's why I mentioned this, because we're studying canines only. Regional teeth are vital. In a clinical case, you will find a large radiolucent area in the mandible, apical to the premolars and molars, on a panorex. No clinical symptoms. Teeth are carious or respond normally to vitality tests. Medical history is unremarkable. No fluid or tissue is evident. Now, that is a traumatic bone cyst. Now, a lateral periodontal cyst. A lateral periodontal cyst will be mostly found in canines, mandibular canines, and premolars and mandibular premolars. Its origin is inflammatory. Remember that mandibular canines and premolars have the thinnest attached gingiva, so it makes sense that it will be due to an inflammation, because they reach bacteria can reach deep areas easily. So inflammation in origin and forms along the lateral surface of the tooth. It forms at the root apex. If it forms at the root apex, is a radicular cyst, but 95% are found in, like we said, mandibular canine and premolar areas. A position with the root of a vital tooth, usually asymptomatic. In the radiography, you will find a well-defined round or teardrop-shaped radiolucency with an opaque margin along the lateral surface of the tooth. Histologic features: thin lining of non-keratinized epithelium. Now, a gingival cyst is the next one, and it's a rare circumscribed swelling of the gingiva, usually found in canine and premolar areas of the mandible. And this is the same reason that we mentioned in the last pathology, which was the lateral periodontal cyst. So a gingival cyst will be mostly found in canine and premolar areas, usually limited to gingiva. The largest cysts may erode the bone. Gingival cysts are easily excised. So another pathology, in this case a tumor, that it occurs mostly on canines is a tumor which its clinical features are going to be less than 3 centimeters of diameter. Clinically, they will look like a gingival fibrous lesion. They are often asymptomatic, circumscribed unilocular radiolucency associated with the crown of an unerupted tooth, mostly canines. That's what we're mentioning all this, because it's canines. And this pathology is an adenomatoid odontogenic tumor, or adenoameloblastoma. The adenoameloblastoma, or adenomatoid odontogenic tumor, is a tumor of ectodermal origin, purely epithelial. And if it's completely ectodermal, it makes sense, because ameloblastoma, enamel, and glands, so it's all ectodermal. They represent 3 to 7% of all odontogenic tumors, limited to younger patients, 10 to 19 years old, and uncommon in patients of more than 30 years old. Not a variant of ameloblastoma, which is best described as a hamartoma, not a true neoplasm. And they occur mainly in the anterior maxilla, 2 times more common in maxilla than mandible. And why is it mostly known, best described or best classified as an hamartoma? Because it is not a neoplasm, because there is an origin that is known to be because of ectodermal origin, as it's causing or the reason why they come is it's because of ectodermal tissues. So limit to younger patients, no more than 30 years old. Not a variant of ameloblastoma, because it's best described as a hamartoma, not a true neoplasm. It's not a neoplasm, it's a hamartoma. So occurs mainly in the anterior maxilla, 2 times more common in maxilla than mandible, and 2 times more in females than males. They affect generally the second decade, and they are asymptomatic or painless swellings. So in its clinical features, you will see most are small, being less than 3 centimeters in diameter. Clinically, they look like a gingival fibrous lesion. They look like a gingival fibrous lesion. They are often asymptomatic, circumscribed unilocular radiolucencies associated with the crown of an unerupted tooth, mostly canines. Important: adenomatoid odontogenic tumors, or adenoameloblastomas, mostly canines in the second decade of life. Radiolucency sometimes extends apically along the root past the cemento-enamel junction. Helps distinguish, and this is something that helps distinguish it from a dentigerous cyst, and is that the radiolucency extends apically along the root and past the cemento-enamel junction. Because a dentigerous cyst is only associated with the coronal part of the tooth, generally around the cemento-enamel junction. So if the lesion goes below the cemento-enamel junction, you can think of a adenoameloblastoma, or adenomatoid odontogenic tumor. May be completely radiolucent, but often contains fine snowflake calcifications, which are going to be tiny radiopaque foci. The histologic uh, characteristics of adenomatoid odontogenic tumor or adenoameloblastoma is going to be a well-defined lesion surrounded by a thick fibrous capsule, the enamel organ lining of dentigerous cyst, reduced enamel epithelium, and rests of malassez. They are derived from ectoderm, so they are epithelial in origin. So derived from ectoderm, enamel organ, and remnants of dental lamina. Microscopic features. The tumor is composed of a spindle-shaped epithelial cells that form sheets, strands, or whorled masses of cells in a scant fibrous stroma. And this, again, microscopic features. The tumor is composed of a spindle-shaped epithelial cell that form sheets, strands, and whole. Well, this is not important for exam, but the treatment is going to be it is completely benign, and its capsule allows to enucleate easy from bone. The recurrence is rare and is not aggressive. The important part of this is to remember that it's going to be found mostly on canines. Adenomatoid odontogenic tumors, also known as adenoameloblastomas, second decade of life, mostly in women, in anterior maxilla, mostly canines. Okay, and the way to differentiate it from a dentigerous cyst is that adenoameloblastomas or adenomatoid odontogenic tumors, the radiolucency extends apically past the cemento enamel junction. So sometimes, not all it doesn't have to be all the time, but it just helps to see that cemento enamel junction in a dentigerous cyst will be the limit for the cyst, and adenomatoid odontogenic tumors can cross that cemento enamel junction line. Now, a compound odontoma is derived from ectodermal and mesenchymal components of tooth germ, affects ages 20 to 30 years, and is common in maxillary, incisor, and canine area, but may also appear in mandible, canine, and premolar area. They are more common in the anterior teeth. A compound odontoma. They may cause delayed eruption of permanent teeth, may prevent eruption of teeth. Its radiographic features of compound odontoma is that it appears as groups of small radiopacities, multiple small tooth-like structures within it, radiolucent rim at the junction with surrounding bone, between the maxillary premolar and the central incisor and the panorax. Multiple small malformed teeth composed of dentin, enamel, and cementum, enucleation, and does not recur. Remember that patient we saw that had two which looked like compound odontomas. Mi amor, ¿tú quieres tu salada? So that's a compound odontoma. So now pseudocysts, which pseudocysts are not true cysts because they have no epithelial lining, but a traumatic bone cyst, which is a pseudocyst, is a non-cyst found in the in the mandible between the canine and the ramus of mainly teenagers, assumed to be caused by trauma. It manifests as painless, well-defined radiolucency that frequently extend between the teeth with a scalloped appearance. Although sometimes asymptomatic, it may produce jaw enlargement. Pain is rarely associated with a lesion, and regional teeth are vital. Also known as simple bone cyst, hemorrhagic bone cyst, unicameral bone cyst, extravasation bone cyst, idiopathic bone cyst, and solitary bone cyst. All these are other names to name a pseudocyst. The treatment consists of opening the lesion, curettage, and closure. It may contain blood, serosanguineous fluid, debris composed of mainly of a blood clot, or may be completely devoid of solid material. Nursing bottle caries, which is a baby bottle tooth decay or bottle mouth syndrome, is a widespread caries destruction of the deciduous primary teeth, most commonly affecting the maxillary incisors. Inappropriate feeding of children may cause a typical nursing pattern decay. There is an early carious involvement of the maxillary anterior teeth, followed by maxillary and mandibular first molar and mandibular canines. Again, early carious involvement of maxillary anterior teeth, followed by maxillary and mandibular first molars, mandibular canines. Mandibular incisors are less affected since the tongue covers them. They are also known as early childhood caries, nursing caries, bottle caries, and infant caries. Nursing bottle caries is rampant decay due to sleep time bottle feeding combined with streptomutans activity. The stagnation of milk around the necks of anterior teeth and fermentation of the disaccharide lactose also contributes to the caries process. Now, talking about tooth discoloration, you're going to find porphyria, cystic fibrosis, erythroblastosis fetalis, which we were talking about, tetracycline therapy, and canines are affected also by these. So porphyria is a condition that results in discoloration of teeth. Cystic fibrosis, the children have teeth that are dark in color, ranging from yellowish gray to dark brown, and may be related to the unusual high doses of tetracycline given to these children in the cystic fibrosis. Okay. Now, erythroblastosis fetalis, there is a primary teeth may have a blue or green color, and this is a destruction of the erythrocytes by the antibodies in a placental to fetus blood circulation, and they are associated with Rh factors. Now, tetracycline therapy can cause tooth crowns to become discolored from yellow to brown and gray to black. The drug stains permanent teeth that have not completed enamel formation at the time of the drug is given. If a 5-year-old child receives tetracycline therapy, the teeth affected will be the canines, premolars, and second molars. Important. Incisors and first molars have already completed enamel formation by this time. So canines are going to be affected by tetracycline therapy in a children 5 years old, along with premolars and second molars. If it will not affect in this particular child that is 5 years old, it will not affect incisors and first molars because they have already completed their enamel formation. So the canines will erupt the canines will erupt okay, let's go to the next one. At age 19 months, 16 teeth have erupted, which are going to be 4, 4, 4, 4 at 19 months. So by the time the baby is a year and a half, he will have 4 centrals, 4 laterals, 4 molars, and 4 canines. In the eruption sequence of a primary dentition, the first molar erupts before the canine. And we will continue this later.